Hi, this is Brian Kim. I want to share with you this case of a patient who was referred for a decentered sulcus IOL. This patient has a fibrotic and eccentric pupil, but he also has this sulcus lens that's a little bit tilted and decentered. So this patient was referred for further evaluation and treatment. So you're going to see how I perform a modified Yamane technique using the Sensar AR40 lens with my modification, externalizing the leading haptic through a contralateral limbal incision, and all the various modifications and techniques to help me execute this surgery. So you can see quite a bit of a retracted pupil, dilated nasally. I'm going to dry the surface. You want to have it perfectly dry. You don't want any wetness, because if you have it wet, the ink mark will seep and won't be discreet. So as you can see here, I use a tip of a 27 gauge cannula, inking the tip and marking the limbus on the right side, using the cannula length to find 180 degrees apart, and then marking the left side as well. This is a fixed caliper by Epsilon. I indent 2.5 millimeters posterior to that limbal mark, and then 2 millimeters adjacent. Making sure it's nice and dry, I mark the indentations on the right side and perform the same maneuver on the left side. Again, using the fixed caliper, indenting 2.5 millimeters posterior to that limbal mark, and then 2 millimeters adjacent. This really makes things so much easier as opposed to using the standard caliper. Using the back end of a 23 gauge trocar needle, indenting the sclera, using the cotton tip to control the eye. With a flat approach with the trocar needle, I tunnel about 3 millimeters towards that 3.5 millimeter mark, and then I dive down, staying flat to the sclera, perpendicular, and I take the needle out. You can see that the trocar cannula is sitting slightly sideways, which hopefully means it's going to be a self-sealing sclerotomy. Make my limbal incisions on the right and left sides to take that lens piece out, my contralateral limbal incision to externalize the leading haptic, and then my incision for the 22 gauge thin wall AC maintainer. This is some intracameral epinephrine and then some dispersive viscoelastic coating the corneal endothelium. This is a 3 millimeter incision. I make a vertical groove, tunnel, and then I enter. You can see that the pupil is rather dilated nasally, and I'm sweeping with the viscoelastic cannula. Of course, I can feel there's significant fibrosis between the posterior surface of the iris as well as the capsule. And so that's what's keeping that pupil distorted like that, the adhesions between the iris as well as the capsule. So I'm just very carefully trying to sweep and separate those adhesions between the iris and the capsule. When you have that focal type of retraction, I do not believe that requires doing a pupilloplasty or anything like that. I want to minimize as much uveal manipulation as possible. So this is the removal of the lens. I'm using 2 forceps, grasping the optic, and then inching my way all the way around using a 2-handed technique to get the first haptic out, the trailing haptic. Switching hands, grasping the optic, and then rotating the optic so that the other haptic comes into the anterior chamber. Now that both haptics are in the anterior chamber, using serrated forceps to hold the lens with my left hand, and then cutting the lens with the scissors, the micro scissors, in my right hand. I'm switching instruments. I always like to grab the right side piece because the right side piece, the haptic will collapse on itself. As I pull that piece out, I shield the cornea and protect it. And then I can rotate the left side piece 180 degrees. And by doing it this way, the haptic will also collapse on itself in similar fashion. So rotating it, grabbing the cut edge, and as I pull the piece out, the haptic collapses on itself, and I shield the cornea with the other forceps. Placing the 22 gauge thin-walled AC maintainer in, start vitrectomy. But as I do this, I can see a Summerings ring piece, which again, I believe has to do with the fact that that was an adhesion to that iris nasally. But I don't want that piece to fall into the back. So what I'm going to do now is take the vitrector out, and I'm trying to grab that Summerings ring and pop it up into the anterior chamber. Now, as I grab it, I see some lines on the Summerings ring. I believe that's probably some capsular remnants or some zonules, but nonetheless, I use a vitrector to cut those adhesions just in case it was vitreous. And then once I cut those adhesions, I turn on infusion, I burp the wound, and the Summerings ring shot right outside. So that was great. Did some more vitrectomy using a Lester to retract the pupil, making sure I don't see any other adhesions. These are my needles for the surgery. This is the 25 gauge needle. I have it mounted on some BSS and syringe, bending it so that the bevel faces to the right. This is the right side needle, bending it 9 millimeters from the tip, making sure the bevel is facing towards the main incision. This is the left side needle. Again, the bevel is facing to the contralateral limbal incision. All of them are mounted with syringes full of BSS. As I'm doing vitrectomy, I inject some intracameral triamcinolone. There's no obvious vitreous into the anterior chamber. And this is the cartridge for the Sensar IOL. This is the emerald cartridge, which is for the Sensar AR40 lens. Push some cohesive viscoelastic on the platform, placing the Sensar AR40 lens onto the platform. And when you place it, you want to make sure that the optic is seated into the cartridge before you bend the wings. As you bend the wings, the optic should bend backwards. The leading haptic should go straight through the barrel and the trailing haptic outside the back end. As I place the cartridge onto the injector, you want to make sure that the trailing haptic is up and out of the barrel so that when I advance the plunger, it won't damage it. Ready to go, place the 25 gauge needle through the contralateral limbal incision, making sure both needle bevel and injector bevel are facing each other. My assistant is advancing the leading haptic. As it comes out, I dock the haptic on the beveled needle. She continues to advance the lens, and more of the haptic goes into the needle. I pull the needle out, and the leading haptic comes out of the eye. I take over, deliver the optic. And then the trailing haptic is delivered outside of the eye, making sure it's swept to the right. Inject some dispersive viscoelastic to protect the cornea and push the optic back down. And then this is the right side needle. I hold the trocar cannula. I stab the conjunctiva and sclera at the first mark, and then I flatten out. I turn on infusion. I flatten out, and I stay basically parallel, tunnel towards that second mark, 2 millimeters, and I dive down. Dive towards the optic nerve, and then you switch to the smooth forceps. You can see here I'm going to gently slide towards the left, but before I do that, I want to make sure that the optic is pushed away from me as much as possible. Sometimes the AC maintainer can actually catch the edge of the optic, so you can see I'm pushing the optic away. The optic is nice and away. It gives me a lot more room now, sliding the trailing haptic into the incision with minimal stress on the haptics, very delicate hand when you do this maneuver, and then I'm turning the needle towards the haptic and not the other way around. That's always the most important thing. Remember, you can damage these very delicate haptics. Turn the needle towards the haptic, not the other way around. I dock the haptic on the bevel and the needle, and 2 small pushes, and I'm in. These haptics do not tend to slip out of the needle, and so you don't have to push too much of the haptic into the needle. And in fact, if you do that, you're going to cause more tension on the optic-haptic junction on the other side. So don't do that. Just 2 pushes is all you need. Disengage the needle from the syringe. And I'm going to internalize the leading haptic, place it into the angle. This Sensar lens is so much better than the C2 Lucia because with the C2 Lucia, the haptic can slip out of the needle, and that just doesn't happen with this technique. Holding the contralateral limbal incision with microforceps, stabbing the conjunctiva and sclera at the first mark, flattening out, staying parallel, tunneling 2 millimeters, diving towards the optic nerve, and I enter. Switching the forceps to the smooth microforceps now. You can see what I'm doing here. I'm trying to get the needle above the peripheral capsule. And you know, a lot of people are different about this. I like preserving the peripheral capsule because whenever possible, I like to have that optic kind of in the sulcus when I can, because that just provides more planar support to give you a nice planar support that's parallel to the iris plane. You saw how quickly I was able to dock the haptic on the bevel of the needle of the leading haptic, and it slid right in. Pull both needles out just a little bit, and then pulling the left side needle out all the way, but limiting how much haptic comes out, grasping it with forceps, drying the surface of the eye with a Wexel sponge, and then cauterizing the tip. A small flange is all you need, and you can see this is not a flagpole sign. You can see how flat that haptic is laying on the sclera. That means I have excellent scleral shelf, scleral support, which means the lens is going to hopefully sit fairly parallel to iris plane. As I pull the right side needle out, I limit how much of the haptic comes out, grasp it with forceps. By doing it this way, you limit how much tension you put on the opposing optic-haptic junction, drying the surface, and then cauterizing the tip. Again, no flagpole sign, nice and flat to the scleral surface. That means you're nice and parallel, which means you have a nice scleral shelf, which means the lens is going to sit fairly close to the iris plane, but also parallel to iris plane, minimizing tilt and ensuring good position of the lens. And then I'm using my serrated IOL holder forceps and just stretching and pulling the iris towards me. Again, there's been a lot of fibrosis to this iris over the years due to the misplaced IOL. And this is the vitrector assisted PI. Again, low flow settings, low aspiration, low cut rate. Make sure that cutter is not all the way into the angle. Make sure you can see the cutter. You want to make that PI similar to if you would do a laser PI. You want to be able to see it. You don't want to place it all the way out to the periphery. Do some more vitrectomy. Placing a tendonal suture to close the main incision. I always do that with these techniques because you never want to take a chance. I'll take that suture out in about a month. Pulling the trocar cannula out, massaging the sclerotomy with a cotton tip, turning on infusion, checking the pressure, nice and firm, and you can see a self-sealing sclerotomy. Taking out the 22 gauge cannula, and then I'll hydrate my incision. So again, this is a patient with an eccentric pupil due to fibrosis of the capsule to the iris. You saw there was a Sommering's ring. You can see that the lens was decentered in the sulcus. I gently pulled the lens into the antechamber, cut in half, and then pulled each piece out, shielding the cornea. Did my modified Yamane technique, externalizing the leading haptic using a 25 gauge needle docking, passive docking technique, thereby pushing the optic away from me. Had wonderful, easy access without any over manipulation of the trailing haptic with the right side needle. And then using the bevel as a landing platform to guide the haptic into the needle, 2 pushes is all you need. You want to minimize how much is internalized. Doing the same thing on the left side, pulling both haptics out, cauterizing the tip, and making sure there's no flagpole sign. You saw that the haptics were laying nice and flat to the sclera, which ensures proper orientation and position of the lens. And this patient was very happy with his result after surgery. So I hope this was helpful to you, and I thank you for your attention.